ECGs and pacing. Okay, so I think we've already touched upon this on the very first day. There's a brief introduction. When you're pacing the right ventricular apex, the QRS configuration is a left bundle branch type of morphology with a left superior axis. There's a bit of a myth about if you're on the septum, you get a negative QRS complex in lead 1. It is a myth. It doesn't work that way. You'll find this in textbooks. Good textbooks, you'll find that, but there's absolutely no proof. In fact, the proof is rather to the contrary. If you have a negative QRS in lead 1, it's possible that your RV lead is actually relatively anterior. Thirdly, if you have a right bundle branch block type of morphology on your paced ECG, that implies several possibilities. The first is that you may actually be pacing the left ventricle. Okay, you may be pacing the left ventricle because you're in there by the coronary sinus, either intentionally or unintentionally. You may be in the left ventricle via a patent foramen ovale, or maybe your right ventricular lead has perforated the apex and is pacing, in fact, the left ventricle epicardially. And rarely, in about 10% of patients, your RV lead is actually in the RV, and still you get a sort of a right bundle branch block type of pattern. And this is just an example that I'm showing you. You can see here in lead V1, a sort of an RBB pattern in V2 as well. And the reason for this is that the leads are placed too high. And this is a very common mistake when performing 12-lead ECGs. They're just placed too high, and this can give you a right bundle branch block type of morphology. And just by moving the leads down by one intercostal space, in the fourth intercostal space as there should be, then you get a normal LBB type of morphology. Okay? Now, it's very important, ECGs and pacing and CRT in particular, not only for your exam, because there are exam questions on pacing and ECGs, but also for your clinical practice, because especially with CRT, I think ECGs play a role, and an increasing role, in patient selection. It's already important now because the only criterion that we have is not mechanical dyssynchrony with echo and so forth, is electrical dyssynchrony with a wide QRS. So QRS width is important. But increasingly we're recognizing, I think Maurizio will be talking a little bit about this, is that QRS morphology is also important for patient selection, and that patients with non-specific intraconduction disorders and RBBs respond less well to CRT. And also, the ECG gives you a clue about possible RV dilatation. And we know that patients who've got right ventricular dysfunction also tend to respond less well to CRT. And we can actually look at this, identify this on the surface ECG. And then ECGs may also be useful for device optimization. I'll be touching upon that. And finally, for diagnosing loss of LV or RV capture. And these are words very important for you also for the exam questions. So just a word on diagnosis of RV dilatation. There's this nice paper by the Dutch group from Wellens, looking at 3 different criteria that may indicate that you have right ventricular enlargement. First of all is a late R wave in AVR. Secondly, you have small, low amplitudes of QRS complexes in the limb leads, defined as less than 0.6 millivolts in this study, implying that you have a very large cardiac volume. And finally, you have very late transition with a negative QRS complex in lead 5, transition only lead 6 or later, implying that you have counterclockwise rotation of the heart because the left ventricle is being pushed away from the sternum more counterclockwise, thereby explaining why you have this configuration. So if you have at least 2 of these 3 criteria, then the likelihood of that patient having right ventricular dilatation is relatively high, and therefore also the chances of him responding to CRT are somewhat lower. It doesn't mean that you should not implant CRT, it's just making it less likely that the patient is going to respond. If you look now onto optimization, and there are different ways of optimizing. You know that there are echo is an important player in this. You have device algorithms, but also the surface ECG. I think very few people are using the surface ECG for optimizing, and maybe you should be doing this a little bit more. Regarding the AV interval, we can diagnose interatrial conduction delay simply looking at the P-wave duration. And if you have a very long P wave duration, then that implies that the left atrium is being activated late, which means it's going to contract late, which means you're going to have left AV dyssynchrony. And when you do bi-V pacing in these patients, it's likely that the out-of-the-box setting that comes in the device is going to be too short. Because the left atrium is contracting late, the risk is that you're going to be truncating the A wave, and that's something that CRT patients just don't like. So look at the ECG, look at the P wave duration. And there's this nice study that actually was able to predict the optimal AV delay by measuring the P wave duration. And what they found was that there was a nice correlation between the AS to P wave end duration and the optimal AV interval optimized by the iterative method. So, in fact, the formula that comes out is that if you add 40 milliseconds to the end of the P wave duration, you're pretty likely to have the optimal AV interval. So that's interesting. And also, if you have a patient with a CRT implanted and pacing, look at that P wave. And if you see that the spike is already on the P wave, it's pretty likely that the AV interval is too short. And this needs then to be confirmed, I think, by echo. So a very simple clue. Now, for VV optimization, there's one thing which is pretty rare, but is important to be able to identify. You may have noticed that some of your patients with CRT, with bi-V pacing, you check the RV thresholds, the LV thresholds, everything is fine, and then you look at the ECG with CRT on, and it looks like the QRS complex is pretty similar to RV pacing only. Okay, because it's a balance between intrinsic conduction, RV capture, and LV capture. And if this is what your QRS complex looks like, it's pretty unlikely that there's much resynchronization going on there. And the reason why you may have this in some patients is that in some patients we have latency. That's to say, if you pace the LV only, between the LV spike and the actual rapid QRS deflection, there may be a close to isoelectric line. And this is because the LV may be positioned in an area with scar. And that means that you'll have slow conduction there. So you have LV pacing, you have local capture in the scar, it goes through slowly, and then it gets conducted more rapidly. So the left ventricle pacing will have a more difficulty in expressing itself. And in these cases, it may be interesting to program an LV offset to pre-excite the left ventricle in order to have better biventricular capture. So these are pretty rare instances. I think in most cases, simultaneous bi-V pacing is okay. But if you do see this phenomenon of latency, then maybe LV pre-excitation may be interesting to program. Is this important? Yes, it is. There was this nice paper here by Michael Sweeney that looked at the large cohort of patients with CRT and looked at the ECG markers. And they found that if the patient had an indication on the bi-V on the CRT ECG tracing of biventricular fusion, then that predicted a higher likelihood of response. Whereas if there was no rightward shift of the CRT axis, that meant that there was very little LV capture, LV participation. This was already in about 23% of the patients. Well, the likelihoods of that patient responding was less good. There are also ways of using the surface ECG for optimizing the VV delay, apart from looking at the latency. This is a group from Barcelona, and they've done a lot of work on this. The first work was published a few years ago, and what they looked at was the pseudo-delta wave. If you do LV pacing only, you're pacing the epicardium, which means that you may get this pseudo-delta wave that represents the delay between the epicardium to the endocardium. And then you get a more rapid DVDT that's due to the electric impulse reaching the endocardium and then being transmitted by the Purkinje network. So this delay, this pseudo-delta duration, was actually quite predictive of the optimal VV delay that they found that predicted the best synchrony by TD echo in this small study, but not very easy to see this pseudo-delta wave always, and you have to measure it at very high paper speed, so it's not very practical. They looked also at the QRS duration as being predictive for CRT response. The narrower the QRS, in fact in this study, the higher the dPdt. This is the difference between the dPdt at the setting and the maximum dPdt. And you can see that if those patients had the narrowest QRS according to this VV optimization method, then they were most likely to have the highest dVdt. And they actually studied this in a randomized trial in about 150 patients, randomized to either echo optimization to ECG optimization using their technique with 3 different settings, either simultaneous BiV pacing, LV offset of -30 or +30 milliseconds. And at 6 months, there was a greater likelihood of echo response in patients who had been optimized by the ECG method, but no difference in clinical response. So encouraging results, but doesn't mean you have to do it routinely in your patients. So that's just to give you an idea of the ECG, importance of ECG in CRT. And I'd like to focus a little bit more now on the diagnosis of loss of capture, either RV capture or LV capture in CRT. This is important not only for exam, but also for patient follow-up. So there are currently 2 published algorithms. The first one here was published by my colleagues in St. Gallen in Switzerland. They did a nice study looking at the 12-lead ECG and diagnosing loss of LV capture. And the first step involves looking at V1. So if your QRS complex is positive in V1, you have a pseudo-right bundle branch block morphology, then you can say you've got left ventricular capture. The second step involves lead 1. And if your QRS complex is negative in lead 1, that means you have a right to left activation, which means that you're getting LV capture. You can stop there. And if you have absence of a positive QRS in lead 1 and a negative QRS in lead 1, then you can say there's a loss of left ventricular capture rather than pacing capture. This works pretty well, but it has limitations. The 2 limitations being that I've just shown you that you may actually have a pseudo right bundle branch block in lead V1 and you're still in the right ventricle if your leads are placed somewhat too high. So that's one caveat. The second caveat is that you can actually have a negative QRS in lead 1 and you're actually pacing the anterior right ventricle. So the specificity of this, I don't think, is necessarily all that high, but useful to look at. Now we can look at QRS axis changes. We're looking at 2 different ECGs and looking if there's a difference in the QRS axis. And as I told you, if you pace the right ventricular apex, your QRS axis is going to be in this sector. It's going to be northeast with left superior axis. If you pace the left ventricle, your QRS axis is very likely to be here because the vector is from left, the patient's left, to the right. So it's going to be in this sector here. And with BiV capture, it's going to be somewhere in between, depending, of course, on the contribution of the right and the left ventricles. Okay, so bearing this in mind, you can see that lead 1 is most likely to show differences in capture between BiV capture and RV only pacing, or that's to say loss of LV capture. Okay, that's lead 1, which is going to show you a right to increasing positivity with this configuration. Lead 3, however, is most likely to show a change between BiV capture and LV only capture, or loss of RV capture, because this is where you'll get increasing positivity in lead 3, right? Because it's really perpendicular to this. So you have to bear that in mind. And there was this algorithm that was devised 12 years ago, published in PACE in 2000, used essentially for threshold tests, because in those days, CRT pacemakers had, in fact, a Y connector. So you had a common LV and RV channel that had a Y connector within the device. So you could not separately assess LV threshold and RV threshold. Threshold tests were done by programming a high output, reducing progressively the amplitude, looking for a change in the QRS morphology, a first change, and then secondly, when you had loss of capture. That was how it was back done done back then. Now, of course, we do this differently. So this algorithm, in fact, supposes and it assumes that BiV capture is present initially. That's what it was devised for. And if you have an increase in positivity in lead 1, that implies that you're going from BiV to LV. That to say that you've lost your LV capture. If you have your increase in positivity in lead 3, that implies that you're going from BiV to LV capture. You've lost RV capture. So let's have a look at this in another way. If you have here, you see, and what we mean by increasing positivity is it may be negative and going to positive, or it may be negative and going to somewhat less negative. This is still an increase in positivity. And it may be positive and getting even more positive. So we're just thinking positive, increasing positivity. So this is an example of a patient who initially has BiV capture and then loses his LV capture and has RV capture only. You can see in lead 1, it goes from negative to positive. There's an increasing positivity. Look in lead 3, there is no increasing positivity. If anything, it's getting more negative. So in this case, we're going for BiV to RV. Okay? In this case here, what you can see here is an increasing positivity in lead 3. Increasing positivity. What about lead 1? No, there is no increasing positivity. Not much change, if anything, a little bit more negativity. So in this case, we'll be going from BiV capture to loss of RV capture or only LV capture. Okay? Good. So, I'll make you think now. For the purposes of this exercise, please consider this 4.0 to be here when you have a change in QRS morphology, okay? There's the 4.0 is here. So I want you to look at this. This is a threshold test. We're starting off at a high threshold and simply reducing the threshold amplitude. And what I want you to tell me is what is the right ventricular threshold and what is the left ventricular threshold. So think about this. You can start voting. Okay, answer 2. Very good. Good. Glad about that. You saw that initially what happens is you get, this is lead 1, so you have an increase in positivity in lead 1. That means it's going from BiV capture to RV capture. So your LV threshold is 4.5. And then afterwards, you lose your RV capture. You lose pacing altogether. Good. So most of you got that right. I'm glad because the concept's not all that easy. There's another algorithm which we've been looking at in Geneva because the algorithm that Young published in PACE in 2000 supposes that initially you have biventricular capture. And that's not always the case because if you have intermittent capture on an ECG, what's the beginning and what's afterwards? There's no start with BiV capture. So it's very simple because you know that if you have narrowing of the QRS, you're going from univentricular pacing capture to biventricular capture. It's that simple. If the QRS is widening, you're going from biventricular capture to univentricular capture, so all the way around. And sometimes it's unchanged. And when it's unchanged, it's always the right ventricle that's pacing alone, univentricular right ventricular capture or biventricular capture. Sometimes the QRS width with RV pacing only is not that wide, especially if those RV leads are on the septum, as there are more and more today. And in our study, we also included patients with RV leads on the septum. So if there's no change in QRS width, it's a difference between BiV capture and RV capture, but we don't know in which direction it's going. And then you look in lead 1. As you increase LV capture contribution to the QRS complex, there will be an axis shift towards the right of the patient. Okay, the more the LV participation, the greater the axis shift towards the patient's right, as we saw from that graphical display. So bearing this in mind, in fact, taking these two things into account, you can actually work out what the combination is in any order with about 90% accuracy, We haven't published this, I have to mention, but it's undergoing revision right now. So just to show you one example here, you can very clearly see the QRS is getting narrower. So this must be univentricular pacing, and this is biventricular capture. Now, that's okay. The question is this RV pacing only, or is it LV pacing only? And you can see that the QRS complex here is a lot more negative than it is here. So this must be LV pacing. This is LV pacing, and this is biventricular pacing. It's very simple. Now here, the QRS width is wider here than it is here, so this is biventricular capture. This is univentricular capture. Is it RV pacing or LV pacing? What you can see is that there is increasing negativity. So the axis is being shifted towards the patient's right. So that means that there's an increasing participation here of LV, and this means that this is only RV to LV. Okay? Here's an example where the QRS width does not change that much. If you measure the QRS width, it's wide here, and it's still very wide here. There is a change in QRS configuration, though. So no change in QRS width. So one of these two is bi-V capture. Which one? We don't know. But we know that the QRS axis here is more negative than it is here. So this here is bi-V capture, and here loss of LV capture with RV capture only, because of the axis shift in lead 1. So that's the way it works. And the reason why this is important is because you may have intermittent loss of capture. As in this example, you don't necessarily suppose that initially you have biventricular capture. So here we can see that the QRS is somewhat more narrow than here, and that the QRS is getting more positive here in lead 1. So this is bi-V capture, and this is RV capture only. Okay, any questions on the algorithm? Yes? Maybe you can just speak up loud.
How you can exclude a potential left ventricular anodal pacing pressure?
Okay, so the question was, how can you exclude anodal capture? Well, if you have anodal capture, you're pacing the LV only, you have anodal capture. In essence, you're having biventricular capture. You're having biventricular, so it's the same. You can't really see the difference between biventricular capture with anodal capture or without anodal capture. You sometimes see small differences in the surface ECG, but it's pretty difficult to spot. I'll be coming back to anodal capture also later on. Okay, so I've shown you here 3 12-lead ECGs. I want you to have a look at them and to tell me which one is which. There's one where you have biventricular capture, there's one with RV pacing only, and there's one with LV pacing only. And try and work it out. Okay, so I would like you to look at QRS width, and I'd like you to also look at the way the QRS is changing in lead 1. And here, it's a little bit negative, here it's very negative, and here it's positive. Regarding the QRS width, I'll let you try and visually just work it out. You can't obviously measure this, but just visually try and understand. So have a look at this, and you can start the voting. Oh, good. Very good. So most of you got that right. It's very good. What you saw was that the narrowest QRS complex was given by ECG number 2. So this one must be the biventricular one. Simple. Okay, one of these two is univentricular pacing, right, and one is left. And in this one, the QRS complex is clearly very, very negative and very broad. Usually the widest QRS complexes you get with LV pacing only, because it is epicardial. And so this one must be LV, and this one is RV. Another clue is looking at lead V1. You can see that in lead V1, this is extremely positive, implying that you're pacing the left ventricle. However, note also with RV pacing only, it's somewhat positive in V1, but it's a lot less positive here than it is here. Okay, so this is much more likely to be LV pacing only, and this is more likely to be RV pacing. If you use the algorithm by Aman on this ECG, you would say, oh, there is LV capture because the QRS is positive in V1. Why is it so positive in V1 with LV pacing? Because usually your LV lead is placed in a posterolateral vein. If you do your lateral chest X-ray, you'll see that lead is very, very posterior. Remember, V1 is anterior. So your vector is going posterior to anterior, and it'll be very positive in lead V1. The exception to this rule is if your LV lead is placed very anteriorly in an anterolateral or in an anterior cardiac vein, and then you'll get a left bundle branch block morphology with LV pacing only. So the LV lead position is also very important. Good. Well, I think you all did pretty well. I hope you haven't got too much of a headache after all these ECGs and algorithms and all. But I think you did pretty well on the test. So, thank you.